So I'd like to introduce our next guest speaker. Mr. Rodrick Marriott is the director of the Drug Control Division, and he's here to discuss and clarify the new opioid legislation that has recently passed, including the new regulation that requires prescribing practitioners to electronically transmit controlled substance prescriptions to the pharmacy. Mr. Marriott.
Thank you. And thanks for having me, everybody. I'll just wait till your knives are gone, right, from your tables, just to be safe. All right, so I'm Rod Marriott. I'm the director of the Drug Control Division in the state of Connecticut, and I'd like to go over some of our new opioid prescribing laws that have gone into effect this year. And hopefully I can provide you with some good information that can help you understand what's gone on. All right, so for you guys, there's really three primary issues here. One is the electronic prescribing of controlled substances, which I know you guys aren't worried about at all. The other one is the voluntary non-opioid directive. A little bit. All right, the voluntary non-opioid directive, which you may see some of, and the prescribing limits on opioids in general. First, I want to give you a little bit of context. These are all the different registrations that are with my department. We have 53,000 different registrants in our state. My agency is responsible for all controlled substances, your controlled substance registration, medical marijuana, wholesalers, manufacturers, distributors of drug, pharmacies, pharmacists, and everything that goes with it. We also oversee some of the controlled substances that flow through our healthcare systems. So that's our nurses, 76,000 registered nurses, and the four different facilities. So we have a total of 130,000 approximately people and 21,000 medical marijuana patients that we're all responsible for. Just to give you a little context of where we come from. So the primary reason I'm here today is to talk what amounts to Public Act 17-131. And the one that I know you guys are all interested in, because you're actually quiet, is controlled substance prescribing. So effective January 1st of this year, all controlled substances shall be transmitted electronically. Those prescriptions need to comply with the federal requirements set forth by the DEA. Those files also need to be kept for a minimum of 3 years, although many of you are required to keep data longer than that based on Medicare, Medicaid, things like that. And all of those records should be readily retrievable the same way a prescription would be normally. So if we had a concern about a fake prescription and wanted to see your records, you should be able to provide that during normal business hours unless we've arranged for something else for you. So there are a bunch of exceptions to electronic prescribing of controlled substances. And a lot of this mirrors actually what has happened in New York already. This one is basically your system isn't available. Maybe you have a power outage. Maybe your system goes through temporary periods of downtime where you cannot transmit a prescription electronically. In those circumstances, you're required to document your reasoning for that in your record within 72 hours of it coming back online. We also strongly encourage our providers in these situations and all of the exemption situations to document something on the prescription itself so that the pharmacy fills your prescription without maybe intruding on your practice any more than they would need to. So in this case, you could just write something like electronic failure on the prescription when you write that paper prescription. And it may prevent the pharmacy from making that phone call to you. The next prescription is problems in the ability for the patient, or delays in care is what it amounts to. So if you believe that prescription is so specialized that it may cause a delay in care, you can justify that in your medical record. You can give a maximum of 5-day supply. And really those are kind of things like, the one I go to is my son had his tonsils and adenoids removed. He needed a liquid pain reliever for a period of time. Not every pharmacy always has that in stock all the time. And so in those situations or situations like that, you can give the patient a paper prescription so that the patient can go try to find a pharmacy that has that medication in stock. And there's other things that apply, like emergencies, where you have that night phone call from your on-call where maybe you don't have access to your electronic medical record and you need to get the patient a medication more quickly. You can do it that way. And these are only for controlled substances. For our border state physicians and prescribers, if the prescription is going out of state, you're not mandated to give them a electronic prescription because that state may not even be able to accept it. So if the patient tells you they're going out of state, you can go ahead and write them a prescription or print it from your computer system and sign it manually. Use of the electronic system may inhibit care. So this probably isn't something that you would handle too much, but IV solutions, compounded prescriptions with complicated directions, all may be something that cannot be transmitted appropriately at this time through the electronic format with the standards and guidelines. There may be restrictions on how those things come through. If you feel that that's the case, you can write a prescription, print it out, sign it, and hand it to the patient. Again, we really encourage, if you don't want to get that phone call from the pharmacy, of saying the reason why you chose to do that. And this is the big one. This is the one that applies to just about everyone possibly, the only who doesn't have this currently today. If you cannot comply with this law because you do not have the combination of technology and software, you can apply with the department for an exemption. Who received an email from us this weekend? Oh, good, almost everybody. If you have not received the email, I'm going to have an email address up on the screen. Please email us. We will send it. Keep in mind, I give you that context in the beginning because we sent out 28,400 emails. I guarantee some of them failed. I'm guaranteeing that a certain percentage of practitioners have not updated their email address with us. So there was a subsequent email that followed it that came with your password, and that password, the first email address, or the first email that you received has your username, the second one has a password, to allow you to go in and apply for the exemption. There are detailed instructions on our website. I hope to be able to pull that up from the computer to kind of show you where that is today. I also have some links in here for you to see detailed instructions. But it's a 4-question exemption process. What type of practice? Do you regularly practice with a computer? Can you currently comply with the DEA requirements for electronic prescribing of controlled substances? If you answer yes to 2 and 3, then you cannot proceed to 4. If you answer no to either one of those, you proceed to 4, and you can ask for the exemption. And that's it. That's all you have to do. And if I can get onto the web and do it okay, Dr. Linker gave me permission to show you what it's going to look like on the outside. And as the year progresses and we get closer to January 1, I'm going to publish a list of all practitioners that have successfully applied for the exemption, so that our pharmacies can go and look for it and hopefully reduce the impact on our prescribers. There's more about that there. So my hope is that by doing this in a digital format, it reduces the impact on our prescribers. It's a quick, easy form to fill out. We understand that not every practitioner does this make sense for them to invest a significant amount of money to get this added onto their system. So we have the ability to do this process at this time, and in any one of those combinations of capacity, whether you don't have a computer or the DEA requirements, it exists for this purpose. So right now we've actually had about 1,500 people complete our questionnaire already, and we've received over 400 emails. We just sent this out on Saturday. And because I'm such a dedicated employee, on Saturday and Sunday, I actually was trolling our email, responding to people to help reduce the impact today. By the end of the weekend, we had 300 people complete the questionnaire already. I was actually rather impressed by that. And so the pharmacists have a similar, they're mandated to accept it. So if you find a pharmacy that doesn't accept it for whatever reason, please let our office know. Via the email address, I'll give at the end again. Same kind of thing for them. And here's where you can see more information is a link on our website. Again, I have some more links at the end, and these slides will be made available, at least from me, so if you guys wanted to get them later, that would be fine. So why do we want to do this? Why is this a problem? I'm just going to give you a couple of quick examples. This is just from 2016. Luke Montgomery of Westport was arrested for stealing a prescription pad and trying to fill 3 fake prescriptions. And there's a link for that there. But these are the real ones. This person and basically a group of people was stealing your identity from probably your prescriptions, not necessarily all dentists. And they passed over 800 fraudulent prescriptions with 270 different patients. This gentleman worked with David Thompson. And they got more than 80,000 tablets of oxycodone. This is kind of one of our original kind of big timers. This guy would drive up and down the 95 corridor, stopping at pharmacies. He had an ornate, very well-organized log book for every patient that he used at every different place. And he was able to obtain 16,000 tablets that we know of, right? I mean, we can't catch every single fraudulent prescription in these cases. But they're very, very serious. And this is one way to combat some of that. It's one piece of our record keeping that may help prevent some of this opioid epidemic from even starting. So I took this data out of SureScript. They've been providing me updates on what the electronic prescribing looks like in Connecticut. As of September, we have around 21,000 prescribers, according to them. We're up in the number of people that have active e-prescribing. That's all e-prescribing, that not necessarily inclusive of controlled substance e-prescribers. And you see our percentages, and they for this purpose, they actually carve out our dental numbers as well. So even since December of 16, so approximately a year ago, we've seen an increase in the number of active e-prescribing dentists and those with electronic prescribing capability. And that may work for certain dentists and certain practices. It may be the way that they want to have their standard of practice. But we have this exemption for those that choose not to do so at this time. Now, if you do have it, if you have all of those criteria, you do not qualify for the exemption, the broad exemption. So if you have it all in place now, you have to use an electronic prescription to transmit a controlled substance, unless one of those other 4 exemptions exist. Go ahead. If you choose not to prescribe opioids, you're probably not going to go through the expense of getting EPCS certified. So I would fill out the exemption if I were you, because if your software is not certified to transmit electronically, fill out the exemption. Because if you don't, you may end up having to answer a lot more questions from pharmacies and potentially my agents. So there's some generic numbers. Nobody really wants to just stare at numbers on a screen. Go ahead. So the question was basically, if you only write 5 prescriptions a year, do you qualify for an exemption? I pretty much outlined the exemption process altogether, in that if you don't even get certified, you have to pay to get the certified software. Unless your software vendor provides it for free in your module, then you have to pay to get it. That's the way they charge you. They charge you that price to go through the DA criteria. If you don't get that feature, then you qualify for an exemption. Does anyone have any more questions about EPCS? I will be available after for... Go ahead. We're not obligating you to get any software addition. So you're obligated to, if you choose not to get the software, the additional software, the only obligation you have is to apply for the waiver. If you don't apply for the waiver and you write a controlled substance prescription and we find out about it, there could be repercussions for that. I'm going to come, it's at the end, on the end of my slides. All right. So has anyone heard about the voluntary non-opioid disclosure or directive? So it's a really quick form. It's a form on the website of the Department of Public Health. Our department commented on it. I have a view of it in the next screen. Basically, any patient can give you a document asking not to be treated with opioids, but it can be removed either verbally or in writing very quickly. If you have that document and the patient provides it to you, and obviously you should attempt in every way to do that. But if you go to honor that agreement, but if you go into a procedure with a patient where they may be in pain, it would probably be prudent for you to express to them that the treatment of this procedure may be best suited with an opioid at some point in time. You provided me with this directive not to give you any opioids. I just want you to understand that going forward. I'm not going to treat you with opioids unless you release this form. The form is a 2-pager. It's fairly straightforward. It's on the Department of Public Health's website. And really, I don't know how many of them you're going to see. But if you do come across it, they've provided an instruction page at the back end of it to help understand it. The highlighted part is for pharmacists because they're not necessarily going to know that you have this in place, that a patient has it in place. But you may see some of them, and you should honor it, but understand they can verbally remove it or remove it in writing. For your protection, you may want to have them do it in writing, especially if you're getting into a procedure where you know that there's an expectation that they're going to have some pain after, and then an opioid is the standard of your treatment. So the next is general opioid prescribing restrictions. So in 2016, they put a restriction on first-time opioids prescriptions for a 7-day supply. So if you were writing one Percocet every 4 to 6 hours, that would be potentially a 42-tablet prescription. If you do 1 to 2, it's more than that. Obviously, it's 84. But ultimately, that's the restriction. But there is professional discretion in there. I don't know how many of you actually write prescriptions that are greater than a 7-day supply or even would feel comfortable with that. But that is the restriction in the law. If you went above and beyond that, I would encourage you to document your rationale in your medical record. In 2016, a minor patient under 18 was allowed 7 days as also, and last year they reduced it to 5. They're finding that some of our addiction issues start with tooth pain that are related to maybe wisdom teeth removals, extractions, things like that. And the idea, when we start to restrict days' supply, the idea is we don't want a lot of medication hanging around in people's cabinets. We really want to keep it to the minimum necessary amount of these drugs. They're very powerful, they're very potent, they're very dangerous. I think if you haven't heard about it, I don't know what you guys are doing because you really must be hiding somewhere. And if you find out that, if you can tell me that hiding place, I would love to know because I can't take any more phone calls this week. It's getting crazy. So anyway, the other thing that should happen is every time you provide a prescription for an opioid, you need to document the dangers, the risks of addiction and overdose, the dangers of taking them with a benzodiazepine and other CNS depressants. Does anyone in here prescribe benzodiazepines regularly? Is anyone willing to admit it? No? Okay. Well, the other way that you would know this is if you actually went into the PMP because you wrote greater than a 72-hour supply and saw a benzodiazepine on their patient profile. I would encourage you to address that potential issue and consider how you're going to prescribe those medications based on that. The CDC has alerted us that there's a higher risk of overdose for patients that are on an opioid and a benzodiazepine. It's important to explain the reasons the prescription is necessary and potentially explain those same reasons to the custodial parent or anyone that's with the patient at that time. So that brings me to the PMP. Is everyone registered with the PMP? I hope so. So the PMP has a lot of key features that can help you with the way that you treat your patients, whether you choose to prescribe for them or not. We have interstate data sharing. I don't know if everyone's experienced that, but if you are especially a border provider of care, it may be very valuable. We share with every one of our border states, and 27 total, I think it is now. So New York, Massachusetts, and Rhode Island. We also are sharing currently with New Jersey as well. That's probably where you're going to see the predominant number of patients here. Go ahead. Can you stand up so I can hear you? Yeah, absolutely. So the question is, can a prescriber access the database? Certainly. You can actually even proactively screen new patients if you so choose. You just have to let them know. You have to kind of get consent to do that. I'd encourage you, if you get into any kind of patient relationship, especially new patient relationships, to check the PMP and get an idea of what's going on. People will target dentists for pain relief medication from time to time. And doctor shopping is an issue that does go on in this state. I mean, the people that are looking for these medications oftentimes get very, very desperate. I actually heard recently of someone in our state hurting their pet or a pet to get prescription medication from their veterinarian so that they can abuse medication. So when you start to think about those things, this tool is there for you to help you. That's why we created it. And so, yeah, we make you change your password from time to time. And we have different things that you're mandated to do with it, but we really want it to be a valuable tool for you in the way you practice. Go ahead. Only on an initial. So if you are seeing a prospective patient, any prescriber and their delegate can look up a patient. But if a person's saying, I'm coming in, they're not yet technically a patient, right? So if you've already had a treating history with them, that's part of your normal course of treatment. When they're there for that appointment, you can certainly check them. Sure. So the question is for the maximum prescriptions, can you write another prescription after those days are over? And yeah, you can write it. The idea is to restrict it so that there's not that much drug hanging around, so it's not abused. You can also see medical marijuana information in our PMP, which is a unique feature that no other state has, or at least that I know of at this point. And some places are starting to integrate the PMP directly into their electronic health record. So when you log into your electronic health record, you just click a button right inside it, and it runs the PMP for you. And one of the other key features that you guys have now also is delegates. So if you have a trusted office member, an office staffer, they can become a delegate for you and run the PMP on your behalf. They can also run batches at the beginning of the day and put them with all the charts. And those are tools that may be valuable for you depending on how you practice and what you want to do with your practice. This is more of a friendly reminder and kind of tells you what drugs are reported. So OxyContin, hydrocodone, marijuana, methadone, morphine, Ritalin. I have not seen a lot of dentists write Ritalin, although sometimes they do attempt to do so for themselves, and that's usually when I do see it. And then there's testosterone and Tylenol number 3, Valium, Xanax, Darvocet. Xanax is the most prescribed drug in the state at this time in our PMP. And then there's the Schedule 5s, Lamodal, Robitussin, Lyrica. So who can access it? The prescribers for their patients only, right? We're not looking up our friends or our family or our neighbors. We really need to protect this information like we would protect any other information. And it's really important that if you do get a delegate, that you explain that to them expressly. It's very important that we maintain the integrity of this system so that it continue to be a valuable tool for our prescribers. Pharmacists can look it up. So when a pharmacist looks it up and places that call to you, I'd encourage you to take that phone call. If a pharmacist is calling you about something, they're as busy as you are. So they're clearly worried about something. And they may have valuable information for you that perhaps you missed or you didn't have access to at the time. And law enforcement can look at it for specific cases, usually limited to detective units. So in July of 2013, every one of our registrants that have a controlled substance registration have to be signed up for the PMP. And any prescriber who dispenses drug from their practice location, not prescribes it, has to upload that data, like a pharmacy would. In 2015, if you write a prescription greater than a 72-hour supply, you have to look up that patient in the PMP, unless it's a continuous prescription. But how many dentists in here write continuous prescriptions for controlled substances? Okay. So really that exemption doesn't apply to you. And then, so there's a prolonged treatment exemption for that, and Schedule 5s, there's once a year. Schedule 5, predominantly it's going to be prescribed regularly, is Lyrica. It's a neuropathic pain reliever. In 2016, our database became as close to real time as we were going to get at this time, so within 24 hours. And so it's really great that we have access to this information so quickly, really at our fingertips, so that our practitioners can make the best decision that they can at the time of care. If the PMP is down for a period of time, you can write a prescription greater than 72 hours, but when the PMP comes back up, you have 24 hours to review it. Now, that prescription is probably going to be long gone, especially if you find out that person's a doctor shopper type. But at least you have a documentation so that you maybe don't do it again. And in 2016 was when we allowed delegates to open up. It wasn't just a licensed medical professional. We opened it up to basically anyone that you choose. But you understand that there comes responsibility with that. So here's our website for the PMP. It goes through a lot of these laws and public acts, and may be very valuable for you to, as a refresher, mark it in your favorites. I see a lot of people taking pictures. I'll just pause for a minute there. And so the PMP has been a very valuable tool for prescribers in our state. And again, it really comes down to allowing you to have information that you may not have otherwise. Here's the registration process. Oh, go ahead. Did everybody hear that question? So the question amounts to, what does the electronic prescribing of controlled substances law do other than cause an increased cost to our practitioners? Is that a fair synopsis? Okay. So what it does is it provides, the reason for some of the cost is that there is a high level of security and a two-factor authentication in the transmission of a prescription from the prescriber to the pharmacy. That should limit significantly the amount of diversion and diverted prescriptions from people like those slides I showed before, the 80,000 tablet people that are costing our healthcare system a significant amount of money, as well as creating new addiction issues. And ultimately, as these people come off of these medications, they're now chasing things like heroin. Our heroin in our state right now is laced with fentanyl. How many of our dentists here are familiar with fentanyl? You ever prescribe it? No. Super potent drug. None of our people that are doing this illicitly, most of them don't even know it's in there. And when they do find it in there, they usually don't come back. So we've lost over 1,000, we're on pace to lose over 1,000 people this year to overdose. And this is one mechanism to help reduce fraud and abuse of these opiates that are tracking, oftentimes are starting from our legitimate medical prescriptions, and then getting kind of bastardized by people that are trying to divert the medication. I can't tell you how many times as a patient I've walked into an office where I've seen prescription pads sitting out on someone's desk. Is anyone guilty of that here? No? I bet your staff has taken them from some of our dentists here. Go ahead. So the question is about 100% e-prescribing for all medications. So my division doesn't oversee necessarily the prescribing of non-controlled medications. I think that as adoption of electronic prescribing, there is still carve-outs and exemptions to some of those other states, kind of like what we have. New York still has their exemption. Their road was very rocky. They started in like 2012. I don't know how long it's going to be before it's a full mandate that all prescriptions are transmitted that way. So it's really hard to say that for sure. Go ahead. Can you stand up so I can hear you, please? So that's the two-factor authentication. That's why the software costs money, because they have to verify that there's appropriate security measures on the software. So it's you logging into electronic prescribing software and another factor of authentication, whether it's a token, kind of like a RSA key. Does anyone have those? So it's an encryption key. They kind of look like this. It has a number that scrolls and changes every 60 seconds. I have an encryption key to get into my computer so that people can't hack my computer. It's the same kind of thing to help increase the security. Look, is any system perfect? The paper system hasn't been perfect for us to date, right? Your DEA number is out there and adulterated every time you potentially write a prescription. And so the same people that are looking into that will eventually get smart enough to go after this, and hopefully we continue to push our security requirements so that this stays as secure as possible. Yeah, so your computer right now has the same potential problem in your office. So here, how much more time? We're running out of time? Okay. Yeah, so for now, we're going to stop with the questions. You can come see me at the end. I'm going to go through my slides, and we'll continue to address this after. So if you look in here, this is the dashboard. There's certain alerts that will come up for you to alert you to potential doctor shopping, patients with high opioid prescriptions in it, so greater than a 90 morphine milligram equivalent. Is everyone familiar with the morphine milligram equivalent? Basically, it's a normalization ratio to help you have an equivalency in what was prescribed against morphine. And those alerts will come there. There's a doctor shopping alert, which is one patient with 5 or more pharmacies and 5 or more prescribers in a 90-day period. Not every one of those people necessarily is a doctor shopper, so you need to make sure you look into it a little bit further, but it's an alert that points you in a direction. And the last one is that opioid and benzodiazepine alert. It's basically if those two drugs are used in combination at all. So when you look in, if you are not certain of the patient's name and spelling, you can check boxes to allow for better searching. And you can, on the right-hand side, you'll see different states that you can select to search it, the PMP, based on those data sharing agreements. We're up to 30 states, and Washington, D.C. And this is what a report looks like. This patient has mostly prescriptions for clonazepam. And this is what a full alert when you download it looks like. I'm not going to go through these. I'm sure most of you have seen them. The data is not perfect, so you have to verify it from time to time. It's always valuable to do that. If a patient says, I didn't get that, it may be important, and you can just call the pharmacy and get that information. And it's a tool. It's a tool to help you, to hopefully help you prescribe better. You can also search your own name, and this is a great way for you to help identify fraud that's going on in our system. And this is kind of an idea of what one of these looks like, the practitioner history reports. Those notifications I was telling you before are going out from our system too. Same 3 notifications. High morphine milligram equivalent, benzodiazepine and opioid, and doctor shopper. And this is what some of the alerts look like in our system when you see them. They come up with a big red. Again, the benzodiazepine, opioid, and a high MME. So, interestingly enough, in 2010 we did a little bit of a study on our PMP usage and dentists, and New York and Texas also did it concurrently. And we found that the percentage of the dental prescriptions in our PMP was only 4%. And the average dose across the board was approximately 60 tablets total. And the average dose, the doses per patient in the dental group was like 8 dosage units. So it's a pretty low amount, right? It's just a few days supply in most cases, depending on what medication you're writing. Again, this is only controlled substances. The percentage of all dosage units for dentists is about 0.48% of all the dosage units in the PMP at that time in 2010. We've not repeated this study. And this is the percentage of dental provider reports requested, so the dentists really aren't looking up people in the PMP at this time. There was no hard mandate at the time. So it's just kind of interesting to show that, that these are what our numbers looked like in 2010. I'm sure the numbers and lookups are up. I don't know how much is less now. The other thing that's really important that I just want you to know is getting our drugs out of our cabinets is really important. And as you see our patients come into you and they have had prescriptions that they're not using, teaching them where there are drop boxes, giving them resources for that. There's a one-page flyer that you can hand to them for getting rid of medications. We're fortunate in our state that most of our trash is incinerated, so you can dispose of them in the trash. You just want to conceal them. There's directions on our website for that. We have over 80 police drop boxes for patients to drop their medications securely and anonymously. We also have the opportunity with DEA take-back days. We just went through one October 28th. And sometimes there's local take-back events as well. And in the near future, when our regulations pass, we'll have pharmacies with drop boxes as well. So here's the email address. Please be specific about what you're talking about. People say, I need my username and password, but I have a PMP with username and password issues, and I have an e-license system with username and password issues. Our information can be found on our website. Calling is probably the worst way to get in touch with us right now, only because our phones get jammed up. I have one person on phone duty a day, and it just so happens I released this with my infinite wisdom when my secretary was on vacation. So, we really want to make sure that we're able to help you through this process. We tried to make the waiver as easy as possible for you, and hopefully I can kind of show you one quickly if I have enough time to do that. Maybe ask me to have all questions held to the end. All right. So if you see there, I'll click you kind of through these links quickly. It's right at the top of our drug control divisional page, the electronic prescribing of controlled substances. You'll also see there's a link to the Public Act, so you can review it if you so choose. It's a really great read for 10 o'clock, so you can fall asleep and don't need Ambien. There's a frequently asked questions to help you through some of this. I actually specifically addressed the part about cost, the additional cost of electronic prescribing, and that you do not need to buy something just to comply with the law. You can opt for the waiver. So there's those instructions there, and I will show you what it looks like so that you can see once you've completed the waiver what it will look like. And there will, like I said before, there will be something that we print out or publish on our website as the January 1st deadline gets closer. Well, I guess while I'm waiting, if there's any questions, I can answer some now. I'm sure that would help in certain instances. There's a number of different things that we can do. There's been a lot of data out there reporting that prescriptions tend to be the genesis of this, whether they're illicitly moved because we've prescribed too many and they're hanging around someone's house, or the patient gets addicted just from their first few doses. It's a multifaceted approach. No one way is going to stop this. It's just unfortunate at this point in time we have such a large volume of fentanyl in this product that our patients just can't handle. And when one of the big overdose issues that happened down in New Haven was all fentanyl that people thought they were getting cocaine. We're never going to be able to defense against all of those things. But some of it starts at the way we prescribe medication and some of the tools that we can provide to our prescribers of these medications. So this is Dr. Linker's page. This is what our questionnaire looks like. I ask you 4 very hard questions. Where do you practice? Do you have access to a computer? Can your system comply with EPCS? And so Dr. Linker does have a computer. Congratulations. And he asked for the waiver at this time. It's approved. So now you can see that you completed the waiver. That's it. I don't ask you anything else. And you'll be granted the waiver. We will probably ask you to refresh the answers to these questions when you renew your controlled substances registration every year. You can also update this at any time. So say you decide that it's appropriate for your practice to get this software, you can go in and change your answer using your username and password. Okay, and that's it for my presentation today.